internet-based activity which is approved for 6.7 hours of physician, nurse, and pharmacy credit for today and next Saturday. And the information on how to claim the credit will be available at the end of the conference and can be found in the resource center, which is located at the top of the screen. We would like to thank our educational grant supporters for this conference: Ascentage Pharma Group, AstraZeneca Pharmaceuticals, Janssen Biotech, administered by the Janssen Scientific Affairs, Novartis Pharmaceutical Corp., Sanofi, and Seagen. Without their supports, the conference would not be possible. The faculty and slide handouts can be accessed by clicking on the slides button located to the left under the video window, or by visiting the resource center once each session is complete. I also encourage everyone to tweet throughout the conference using the hashtag HMDLive24 and connect with your colleagues in our networking forum. If you have any questions on how to navigate or interact with the platform, you can send your questions via our Desk Help tab. Please submit the questions to the speakers by clicking on the Q&A session tab in the box to the right of the video window, and questions will be sent privately to the moderators and will not be visible to the audience. As we get started with the first session, myeloma, lymphoma, and benign hematology for today, please take a moment to answer the polling questions by clicking on the polling tab in the box to the right of your video window. And following this, we will have the first update on newly diagnosed multiple myeloma by Dr. Sagar Lonial.
Hello, I'm Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, Georgia. And I'm going to spend the next few moments talking about some of the really exciting data presented at the American Society of Hematology on the context of newly diagnosed multiple myeloma. So let's start off a little bit in terms of the scope of the problem. We know that there are about 35,000 new cases of myeloma that will be diagnosed in 2022. With only, fortunately, about 12,000 deaths expected to occur, which again demonstrates the significant improvement in longevity for many patients with multiple myeloma. Back in 2019, there were an estimated almost 160,000 people living with myeloma in the United States, with an estimated 5-year survival of about 58%. And again, the median age is 69. And while the prognosis has significantly improved, the median expected survival is well over 12 to 14 years, depending upon genetic subsets. And so that, I think, gives you a little bit of the flavor of what we're going to try and address in the next few moments. So the first abstract that I want to present is really an update from the iStop-MM study. And the reason that I want to present this data is that if you're at all like my practice, many of our subspecialty colleagues order a free light chain ratio as part of their diagnostic workup for pretty much anything that they do. And what you'll often notice is that patients with barely abnormal free light chain ratios get referred to hematology, and they're often told that they have multiple myeloma because they have a barely abnormal free light chain ratio. What we see from the iStop-MM data set is really two things. The first is the impact of renal function on the free light chains and the free light chain ratio. And what you're seeing here is for GFRs anywhere from 45 to 59, 30 to 44, and GFR less than 30, we're seeing new standard ranges for both kappa and lambda light chains, as well as new ratios. And I know it's not uncommon for me to get a patient with a creatinine clearance of less than 30, with a free light chain ratio of 2.5, who gets referred to me for myeloma-related kidney failure. And at the end of the day, 9.5 times out of 10, that is in fact not correct. And this new ratio and new absolute numbers here gives us a little bit more comfort in suggesting to our specialty colleagues that perhaps that patient doesn't need an extensive plasma cell workup. Now, at the same time, we know that diseases like MGUS increase with age. And so again, it's important to understand the impact of age on the free light chain ratio and the impact here as well. And what I think you're seeing here is that above age 70, the upper limit of free light chain ratio normality is 2.59. Historically, that's been reported at about 1.8 or 1.9. And so again, I think this gives you some comfort to perhaps not necessarily do an extensive workup for every patient that comes from a nephrologist or a rheumatologist with what has historically been considered a slightly abnormal free light chain ratio. So this, I think, is very practical and useful information that I think gives us the comfort to reassure patients that they don't necessarily have a plasma cell disorder with an abnormal free light chain ratio. Now, let's switch gears to smoldering myeloma. And what we're going to see is some updates on a couple of trials. The first one is the Centaurus trial. And as you can see from the schema here, there really were three groups of patients that got single-agent daratumumab in the context of high-risk or intermediate-risk smoldering myeloma. And what you can see is there was long intensive therapy where patients got multiple doses of daratumumab. There was intermediate, where they got less intensive dosing of daratumumab. And then a third where they only got weekly for one cycle of therapy, single-agent daratumumab in the context of intermediate or high-risk smoldering. Now, this paper has been published by my colleague Craig Hoffmeister, but was recently updated at the ASH meeting. And what you're going to see here in terms of overall response rates is described here for the long intense, 58.5%, for the intermediate, 53%, for the short, 37%. And again, the median duration of responses have not been reached for the long intense, intermediate, and short are about between 70 and 80 months. What I think is really important is looking at both progression-free for the overall phase and then the extension phase. As you saw in the original schema, patients were allowed the opportunity to continue to receive daratumumab in the extension phase. And what we're seeing is that we've not really reached the medians for the long intense therapy, but this does require a more extended duration of daratumumab therapy. And I think many of us are trying to recognize the idea that if we're going to intervene in a high-risk smoldering setting, we really want to talk about limited duration therapy, to be able to maximize this benefit. Now, again, looking at the Centaurus overall survival, again, given that these are smoldering patients, it's not likely that we're going to see a significant change in overall survival. That is an important take-home message for most of the smoldering trials, that we should not expect a difference in overall survival. And as you can see, the numbers are relatively small here, but no significant impact on overall survival with long follow-up. Now, The next trial that I want to talk about was a very small trial, also done at the NCI. This was about 50 patients who received KRD as part of their treatment for high-risk smoldering myeloma. And what I think you'll see is after 8 cycles of KRD, they then got an additional 2 years of lenalidomide maintenance, and then they went on to observation with annual restaging with bone marrows and PET scans. And again, if you look at who these patients were, what you'll see is prolonged biochemical progression-free survival in MRD negative patients. Again, of the patients that achieved MRD negativity, clearly they did well. In patients who did not achieve MRD negativity, the median time to develop myeloma was about 41 months. And this, again, is not unexpected for this intensity of therapy. And I think more importantly, this suggests that while early intervention can make a difference, it does not appear that it necessarily changes the natural history of myeloma. And what I mean by that is what you're seeing is a curve with continuous relapses over time. And I think that that really is important because the goal of more intensive therapy is eradication of the clone. And we've not yet seen that with any therapy. And at least in my mind, it raises the question about whether less intensive therapy really focused on prevention rather than elimination represent the optimal approach for smoldering myeloma patients. Now, the third trial I want to touch on is the ImmunoPrism trial. And this was initially intended to be a randomized trial between either Lendex, teclistamab, or another therapy to be determined. What we really saw at ASH from Dr. Nadim was really the first run-in of patients receiving single-agent teclistamab. And again, it was a total of 19 patients that were evaluated. You can see who these were. Many of them were, in fact, the evolving phenotype. And I put this slide up here really to help people understand that we don't know necessarily that the genomic necessarily predicts faster progression from smoldering to symptomatic myeloma. That is not a decided matter, at least in the field right now. There are data sets that suggest it may be faster, but they have not been validated in larger series. And in fact, an analysis being done by our center in conjunction with 7 or 8 other centers around the country is seeking to pool together over 1,200 smoldering patients to try and better answer that question. So genetics, we think, may be important, but we don't know that they predict for faster time to progression. Of the 12 patients that were reported in this series, you can see there were some infections, particularly a couple of grade 3 infections. So about 1 out of 6 had grade 3 infections. And then you can see other notable toxicities, including grade 3 pancreatitis in this approach. Now, the response rates were very good, as one might expect. 83% of patients achieved a complete remission. 17% achieved a VGPR or better. And in this analysis, they quoted 100% MRD negativity at 10 to the minus 5. So certainly very deep responses. The numbers are very small. The long-term follow-up giving a bispecific in the context of immunosuppression and infectious complications is not very clear. The median follow-up was less than 6 months, but certainly suggests that this data is very robust and certainly does need longer follow-up and larger patient population to understand the impact of a bispecific in high risk or intermediate risk smoldering. So let's switch gears to what I think is really the big and important idea, which is newly diagnosed myeloma. And I really want to focus on a couple of large studies. The first one is the Perseus study, and this was a highly anticipated trial that was a larger version of the Griffin trial, which more closely mimics what we tend to do in the US. This is VRD induction, followed by transplant, followed by VRD consolidation, followed by single-agent len maintenance versus each of those with single-agent daratumumab being given. So dara plus VRD, dara plus VRD, and then dara-len as maintenance therapy. Now, this was a highly anticipated trial because we saw from the Griffin trial that this was clearly positive, but Griffin was a randomized phase 2. This is a randomized phase 3, and with a median follow-up of 47 months, what we're seeing is that at 4 years, the difference in progression-free survival is 84% are still in remission with dara VRD versus only 67% with VRD alone. And this is consistent with what we saw from the Griffin trial. and in my mind, clearly establishes the role of an anti-CD38 plus VRD as part of initial induction therapy. Now, if you want to look at overall and sustained MRD negativity, what you're seeing is 10 to the minus 5 on the left, 10 to the minus 6 in the middle, and then 10 to the minus 5 for greater than 12 months on the right. And what I think you're seeing is increases across the board for the addition of DARA. It's double in the 10 to the minus 6 category, and it's almost, it's greater than double in the sustained MRD negativity. And this, to me, again, is validation that the use of daratumumab can not only contribute to deeper and faster responses, but that translates into better long-term remission, progression-free survival, and sustained MRD negativity. Now, when you look at MRD negativity over time, again, you'll see here at 10 to the minus 5 and 10 to the minus 6, you can see it clearly increases over time, which is, I think, critically important here. You're seeing that post-consolidation versus overall, it basically doubles in both arms here. And that, I think, again, speaks with the ongoing depth of response and is even greater consequence in the 10 to the minus 6 subset of patients. Now, when you look at safety, I think there are a couple of things that we need to keep an eye on. The first is we know that the neutropenia and thrombocytopenia is worse when you combine an IMiD with an anti-CD38. We've seen this in both POLLUX as well as the MAIA trial, where the incidence of grade 3, grade 4 neutropenia and thrombocytopenia is higher in the DARA arm than it is in the non-DARA arm. But this is anticipated and can, in fact, be managed. When you look at other complications, what I think is quite impressive is that the incidence of infections is not significantly higher with the addition of DARA, with perhaps the exception of COVID, where it was 35 versus 23%. And we do see a little bit more in terms of chronic upper respiratory infections with the use of DARA. We know that now requires a little bit more vigilance on our part as practitioners. And I think we know that we're fairly liberal now with the use of IVIG as a way to try and prevent that complication as well. Now, the other large randomized phase 3 trial that was presented was the ISKIA trial. This was a randomized phase 3 trial that was a plenary session talk at ASH, and it was KRD plus isatuximab as the experimental arm. Patients either got KRD, stem cell transplant, then KRD, and then maintenance, or they got ISA-KRD transplant and then ISA-KRD with addition as well. And again, if you want to look, these two arms were relatively balanced between the two, which is always reassuring. And I think you see that quite nicely here. No significant difference in the incidence of high risk or high ISS or high RISS staging patients. And in fact, if you look at MRD negativity at 10 to the minus 5, you can see 77 versus 67% in the post-consolidation subset of patients. If you look at 10 to the minus 6, it's 67% versus 48% with an odds ratio of 2.29. So very significant for the 10 to the minus 6, which, as those of you who know me know, I think 10 to the minus 6 is far more meaningful than 10 to the minus 5. And so I put a high value on that. And then again, if you look post-consolidation, you almost triple the MRD negativity, particularly in the group with 2 or more high-risk cytogenetic abnormalities with the addition of isatuximab over KRD alone. So big differences at 10 to the minus 6, particularly in the high-risk group, but that's seen even in the standard risk and in the one high-risk abnormality as well. Again, looking at safety, you can see here the incidence of infections, particularly neutropenia and thrombocytopenia. Not a surprise. We saw that with the DARA experience before. If you look at thromboembolism, you can see not significantly different between the two arms, likely because both arms were getting carfilzomib, but it certainly does not, it speaks to the fact that there's not an increased incidence when an anti-CD38 is combined with carfilzomib here. And the infectious complications in this series were relatively similar between the two, particularly excluding COVID-related infections. When you look at just COVID alone, slightly higher in the ISA arm, 26 versus 19% of any grade. Now, the third study I want to talk about in the context of newly diagnosed multiple myeloma is our real-world experience that Nisha Joseph from our group presented and updated at ASH this year as well. And this is looking at our RVD 1000 series on the top and comparing it with our DARA RVD 300 series. So patients either got one or the other. They were temporarily separated. We didn't really use DARA RVD until about 2017, 2018, whereas the RVD experience goes back all the way to 2008, 2009. So there is a little bit of a time bias here. And then patients then got risk-adapted maintenance, as you can see here, with either single-agent len or IMiD-PI if they were high risk. If you look at patient characteristics, they were relatively similar, certainly not significant. The only difference that we saw was that there were more 1114s in the DARA RVD group than in the RVD 1000, and there were more patients that had amplification of 1Q in the DARA RVD compared to the RVD experience in general. But everything else was relatively balanced between the two groups. If you begin to look at response rates, what I think you'll see is that VGPR or better, 95.6% post-transplant for the DARA arm compared to 86. If you look at the pre-transplant, 86% for VGPR or better with DARA compared to only 67. Again, this data mimics what you saw in Griffin as well as what you saw with Perseus. And if you look at both progression-free and overall survival, granted, the DARA RVD only has about 2-year follow-up compared to 10-year follow-up for the RVD in red. What you're seeing is 1 and 2-year PFS, 98 versus 93, 93 versus 82. This is almost superimposable with what we saw with Perseus. And in fact, 1 and 2-year overall survival are also very similar to what we saw with Perseus and with Griffin in terms of outcomes overall. And then if you look at the long-term follow-up at 4 years, you'll see PFS at 4 years for the DARA arm, 85% versus 61. Remember from Perseus, this is 84% versus 67. So the control arm did a little bit better in Perseus than it did in our RVD 1000 series, but certainly these are all in the same ballpark for annual intervals for remission comparison between the addition of DARA versus no DARA in our historical data set. Now, I wanted to break this down a little bit by risk. What you'll see here is standard risk, high risk, PFS, and OS. And what I think is really quite striking is that even with early follow-up, the overall survival looks like it's better for the DARA RVD arm in both groups. And most importantly, the overall survival for both groups is still pretty good, even with RVD. So you'll see in the standard risk group, greater than 156 months. In the high risk, it's 72.7 months, so almost 6 years is the median overall survival. We certainly hope that these new therapies will result in improved overall survival for both groups of patients, and at least preliminary data suggests that that is in fact the case. Now, the last of the induction therapies trials that I want to really discuss here really focuses on the IFM pilot study looking at high-risk myeloma. And what you're seeing here is data presented by Dr. Touzeau, again, looking at patients younger than age 66, all had high-risk myeloma at the time of diagnosis, all had reasonably good performance status. And what you see here is induction with DARA KRD times 6, stem cell collection transplant 1, consolidation with 4 more cycles of DARA KRD, then transplant number 2, and then maintenance DARA-len for an additional 2 years. And what you'll see here, experience of about 50 patients, all of them had some form of high-risk genetics, predominantly 17p deletion, 414, 1416, and about 30 of the 50 had more than 2 high-risk cytogenetic abnormalities. These are patients that we know have a very challenging outcome overall. Now, if you look here in terms of who these patients were, you'll see that about 21 of the patients, or 42%, had to come off study. And about 8 of them were because we could not collect stem cells. 8 of them were progressive disease. 8 of them were adverse events, and 1 was withdrawal. So to me, that's about 13 out of 50 that couldn't complete, not because of progression, but because of either adverse events or challenges with stem cell mobilization. This is not a small number. This is roughly 26% of the patients enrolled on this trial. And that, I think, is really important to keep track of. As a consequence, after about half the patients were enrolled, they then went to collecting stem cells after cycle 3 instead of after cycle 6. And what they nicely demonstrated was that they reduced the number of mobilization failures from 6 to 2. That's better, but certainly 8 patients were not able to proceed to tandem transplants due to lack of sufficient cells being collected, even after changing it to 3 cycles instead of 6 cycles for the time of collection. So that is an important thing for us to keep in mind. And we know that one of the most important prognostic factors for high-risk patients is whether or not they get a transplant. And you can debate about the utility of 2 versus 1, but clearly you need 1 in terms of improving outcomes. Now, if you look at response rates, 81% of patients achieved CR or stringent CR, and about 94% achieved MRD negativity at 10 to the minus 6 after transplant. Again, the N was only 33 here, so it probably is not quite that high if you take all 50 patients on an intent to treat basis, but certainly of the patients that got to transplant, of the 33, 94% of them achieved MRD negativity at 10 to the minus 6. If you look at the progression-free survival, at 36 months, we're somewhere around 70% are progression-free. And the overall survival certainly looks very good as well. This really, to me, is food for thought. I think trying to figure out how to get more patients through the entire treatment approach is really important because, as I suggested, 13 of the patients couldn't go further than the first 4 to 6 cycles of therapy because of either progression, mobilization failure, or withdrawal from the protocol. So looking at how to include a larger number in this challenging patient population, I think really is important. Now, the last abstract I want to touch on is data from the EMN26 trial. And this was an ongoing phase 2 study looking at different doses of iberdomide, which is a new cell mod, as maintenance therapy post-transplant. And the reason this is really important is because there is an ongoing trial now of iber versus lenalidomide in the post-transplant setting. And we know that iber is clearly more potent. It's got a better adverse event profile. And so you may be able to stay on iber longer, and you may have a more of an immune-enhancing effect with iberdomide than you get with single-agent lenalidomide. And this was the EMN trial. What you see here is 40 patients per cohort in a randomized phase 2 trial, 1.3 milligram, 1.0, and 0.75. This was all being given without dexamethasone, so single agent days 1 through 21 with a 1-week break. And what I think you're seeing here in terms of adverse events is consistent with what we see with iberdomide in general, which is very few grade 3, grade 4 adverse events outside of hematologic toxicity. We do see a little bit of fatigue, one patient who had peripheral neuropathy, but in general, this fits with the safety profile of iberdomide in general, and I think is really reassuring in the post-transplant setting as well. When you look at deepening of response rate, you'll see 50% of patients deepen their response rate in the 1.3 milligram cohort, and about 54% of patients deepen their response in the 1 milligram cohort, which again, I think speaks to the safety and efficacy of iberdomide in this context. If you look at progression-free survival at 12 months, 90 and 91% in both arms, I think suggests this is a highly effective maintenance approach. The safety profile is really quite good, and we just need longer follow-up to determine the right dose. So I think to wrap up, it's pretty clear that smoldering myeloma does remain an area of pretty significant study, but the approach of either intensive versus prevention remains unclear. And I think an anti-CD38 antibody has now become the standard of care in partnership with an IMiD-PI-DEX combination for newly diagnosed myeloma. I think the jury on which proteasome inhibitor is unclear. I think the jury on maintenance and duration of maintenance remains unclear. And how to manage high-risk patients is something that I think we're all going to continue to struggle with, but hopefully we have the tools to overcome that in the near future. Thank you.
Thank you, Dr. Lonial, for a wonderful presentation. So we're going to try to get to as many questions as we can. The first one, Sagar, is how do you compare the efficacy and toxicity of lenalidomide versus pomalidomide?
Yeah, that's interesting. In terms of potency,
pomalidomide is probably more potent and can overcome lenalidomide resistance, but the reverse is not necessarily the case. Pomalidomide probably has a little bit more immune-enhancing effects than lenalidomide does. Lenalidomide has probably less neuropathy, more and less myelosuppression than pomalidomide does. And we know that in terms of dose modifications, lenalidomide is a little bit more dependent on renal excretion than pomalidomide is, where you make significant dose adjustments with len. You don't necessarily have to make those same dose adjustments with pom.
And Sagar, how do you compare daratumumab and isatuximab?
Yeah, that's a great question. And I think there's obviously been no head-to-head trials. What we know, both from anecdotal experience as well as looking at the trials in comparison, is that ISA and DARA likely are the same. One does not overcome the resistance of the other. And so when you're making a decision in terms of which anti-CD38 antibody to use, to me, the convenience of the subcutaneous formulation is what drives our higher use of daratumumab, but functionally they're the same.
And Sagar, do you think the quadruple regimen now is the new standard of care, or is still triplet okay?
No, I think DARA RVD is the standard. As you saw in our own data set, we made the switch almost 4 years ago, and we're seeing substantial differences in depth of response and PFS compared to what is already a pretty good standard of RVD. So I think at least for induction, the quad is clearly here.
And the quadruplet, with the quadruplet therapy, how important is the autologous transplant? Is it only for the high risk or for everybody still?
You know, that's a question that keeps coming up. And there are those who say if you get a good quad and you achieve MRD negativity, perhaps you don't need a transplant. I actually don't think there's any data that really supports that. And what the therapy, the transplant nihilists, if you will say is there's no difference in overall survival. But the follow-up is only 7 years. And as you saw in our long-term follow-up, the median survival for a myeloma patient is over 15 years, particularly in standard risk. So with 7-year follow-up, you're not going to see a difference in overall survival. And so I think myeloma in many ways has become like follicular lymphoma, where OS is not the right endpoint until you get to late stage or end stage myeloma. There, OS does make a difference, but early on, I don't think it does. And clearly the PFS is at least 2 years longer with a transplant than with no transplant. So I think the benefit is still there.
So then another question. So it appears that the rate and duration of MRD is better with increasing intensity or 4 drugs versus 3. Right. Do you see a survival advantage or a decrease in the organ damage?
Yeah, again, I think the survival question is a harder one to answer in induction. And in fact, I don't think that in the first all the way up to third-line myeloma therapy, survival should not be the endpoint unless the survival is worse in the experimental arm. Obviously, you want to make sure there's no decrement in survival, but I don't expect an improvement in survival for that reason. So I don't think we're going to see it. In terms of organ damage, to me, the FDA accepted endpoint is PFS. And the PFS is clearly longer with the quad over the triplet.
And what is the benefit of consolidation in the Perseus trial?
That's a good question. And that's a Europe versus North America question. We have not used consolidation at our center in almost a decade now. I think that the CTN trial that demonstrates no benefit for consolidation was a valid trial. All it really is doing is giving more cycles of induction. If you really want to do that, then give more cycles of induction. I personally don't think that there is significant benefit to consolidation.
And why has pomalidomide not been studied more extensively as first-line therapy with the quad regimen?
Yeah, that's a label issue, really. Pomalidomide is really currently only indicated once a patient has been exposed to lenalidomide. So the fact that you have to have had lenalidomide before you can get it, from an insurance perspective, from a clinical trial perspective, Celgene has not allowed any induction therapy trials with pomalidomide. What's interesting is that in India, the Indian myeloma group is actually doing a trial of bortezomib, pomalidomide, and dexamethasone for induction. So that's the only one, and they're using a generic pomalidomide. So that's the only data we're going to see in newly diagnosed.
And is it necessary to perform the urine free light chain ratio, or the serum free light chain ratio is more reliable?
Yeah, I'm glad you asked this question because I get patients with urine-free light chains all the time. It's a completely unvalidated and worthless test. The serum-free light is validated. The urine-free light chain assay is not of value. However, a 24-hour urine with urine immunofixation and UPEP is indicated at the time of diagnosis and at salient time points over the course of a patient's disease. But the urine-free light chain ratio, worthless test. I don't even look at it.
And what's your thought about using third generation IMiDs as first-line therapy in the future?
Yeah, I mean, I think we're going to see iberdomide and mezigdomide have some data in combination with DARA, as well as in combination with bortezomib and DARA in transplant-eligible patients. The tolerability and the potency is really quite striking. And so I think we're going to see that data emerging in the next few years.
And in patients with high-risk myeloma, should we more routinely use DARA KRD or ISA KRD or over DARA RVD?
Yeah, I mean, if you look at the data for KRD versus VRD, at least in standard risk, there was no difference in the ECOG trial. And so for that reason, our standard at our center remains DARA VRD, even for high-risk myeloma. In maintenance and in consolidation for high risk, we do use KRD. But in the induction, I think it's a little bit more complicated.
And last quick question, COVID vaccination in patients on anti-CD38, when do you do it?
Yeah, that's a good question because in our retrospective analysis, the single most important predictor of not getting an antibody response to COVID was being on an anti-CD38 antibody. So obviously you want to do it as far away from the antibody as you can, but I think that the CD38 antibody will minimize the response you get with a COVID vaccine.
Thank you very much, Sagar.
Thank
you.
Our
next presentation is by Dr. Vincent Rajkumar, and he will update us on refractory relapse myeloma.